tell you a little bit first about how this event came to be, to give you a little bit of the history. So Dr. Schultz, Sandy, has been the director of the Center for Women's Health and Wellness just for a couple of years now, and what she has done in that short period of time is really remarkable, and I want to highlight some of that work. What has really stood out to me in particular is that she has made incredible efforts to diversify the center in a number of ways, both in terms of who's serving on the advisory board and thinking really carefully about diversifying the content and the potential impact in terms of the types of research and the types of populations that are being served by this center, both on campus and in our community. That is not easy work, and I really applaud the efforts, and I think today's session is one of the outcomes that we're seeing from that effort. And I would just like to say, it's really easy to write a check. It's really easy because Lisa handles all of that stuff for our office, so it's really easy for me to just say, yeah, have some money. But I cannot emphasize enough how much work it takes to plan a series of events like we've had the great fortune to have for the last 2 days. So Dr. Richardson and Dr. Schultz have been in contact with each other for over 6 months. And Dr. Richardson has been so gracious in really listening to some of the needs we felt we had. And she has adjusted and readjusted and asked questions, what do your faculty need? She has just been such a wonderful partner. And then think about Sandy, having to advertise, having to find the rooms, having to do all of this planning, which is the worst part of having an event. If you have not planned an event, I'm telling you, it is a ton of work, and it is not really fun work until you get to the event itself. And so I want you to know also that we learned about Dr. Richardson thanks to faculty in our social work program. Drs. Yarnesia Dyson and Danielle Swick brought forward in the course of these conversations about trying to diversify content. They said, here is somebody that we think would be really beneficial for our faculty if we brought in. So I want to start by thanking them because that was such a wonderful recommendation. At the same time, Sandy and I were talking, and I said, you know, we've been engaged in our equity audit of the Office of Research, and 2 key lessons we have learned is that our faculty want us to become more knowledgeable about and to be better skilled at supporting community-engaged research and qualitative research. And so I said I would be especially motivated to support a series of activities that had that goal in mind, and boy, have these 2 delivered. I am just so excited. We've had incredible conversation over the last 2 days. You should have been at our lunch yesterday, which included over 10 partners who are engaging in work in the community, and we had a wonderful conversation. We had a meeting last night, yesterday afternoon, with Dr. Sharon Morrison, our inaugural fellow for community engaged research, and Dr. Emily Yankee, who directs our Institute for Community Engagement, where we were just pumping Dr. Richardson for what do people need to do this work. We had a wonderful conversation. Yesterday we had our public lecture. There were undergraduates coming up and introducing themselves to Dr. Richardson and us and telling us how the event had impacted them. There was a woman running a local nonprofit passing out her business cards to those in the room. I got to meet for the first time Dr. Richardson's collaborator, who is our colleague. She's part of the joint master's program in social work, but I'd never met her before because she's an A&T faculty member. What a success this has already been. I just really want to say thank you. So I hope I'm not missing anybody, but I want to acknowledge the people that I know of that contributed to today, and that includes Dr. Schultz, Dr. Jessica Dollar, Sharon Morrison, really helping at the end here and getting the community engaged word out on the street, and then the graduate assistants, Becky and Sam. So if you could all wave, let's give them a big round of applause. I'm really, really very grateful to you. And for our faculty, so you know, we do have a funding mechanism. It is for research-related training. And most people apply for that as individuals to go to a training, but I want to remind everybody that there is the option of proposing group training, where you bring the training here so a big group can benefit, and that is the mechanism that is partly funding this morning's workshop. So just a bug in your ear, if you have other needs, remember that that mechanism exists, and we really want to tailor to your needs. So please, please keep that in mind. I told you it was a long run-up, but now for the main event. I am just so delighted to introduce Dr. Richardson to you. She is joining us from the UNC Charlotte University, so just down the road, where she is a faculty member in the Department of Social Work. And now I have to consult my notes because she is so accomplished, I'm going to leave some things out if I don't. But she is an assistant professor of social work, and she also directs the Social Equity Research Academy, and she directs the Mental Health Research and Practice Lab in her department. She earned her Master's of Social Work at UNC Chapel Hill, then engaged in clinical practice for over a decade before returning to get her PhD in curriculum and instruction from UNC Charlotte. She really defines herself both as a social worker and as an educator. And she has important empirical publications in both fields, including really important work related most recently to how COVID is impacting teacher mental health. But her great passion is in her work related to preventing suicide among racially minoritized youth. And that's what she's been talking about mostly with us for the last few days. She's published also 2 edited volumes and has done many, many presentations at scholarly forums and in community forums. And she really partners very closely with the community to engage in this research, and her partners in particular have been Black churches and their congregants and pastors. Governor Roy Cooper named her to a health equity task force in 2020, and in 2021, Dr. Richardson was named the State Social Worker of the Year. So she is somebody who's having an impact statewide. She's earned over $1 million in funding from a broad variety of sources, including foundations, the state, and most recently the National Institutes of Mental Health, and it's some of that work that she's going to share with us today. She's also received incredible training that equips her so well to engage in this research, including being a part of the NIH Summer Institute on randomized behavioral health trials and participating as a fellow in an NIMH-funded program related to researcher resiliency. So we are so lucky to have her and her expertise, and she's going to be talking with us today about strategies for early phase research, developing and refining interventions for minoritized populations. Let's give her a warm welcome.
All right, good morning. So it is really hard to follow all of that, but thank you all for coming out on this Friday morning and spending the next 2 hours with us in this workshop together. This will be a very interactive workshop. I have some activities where you will work with a partner if you choose. And so we're going to do very hands-on interactive work together. I do want to thank the Center for Women's Health and Wellness for inviting me out, and for my talks the last 6 months. Thank you for framing that with Sandy. It's definitely been a pleasure working with you. Thanks to Jessica for all of my rides and our kindred spirits. We have figured out we have a lot in common. We do, including husbands who don't dance. Yeah, our husbands don't dance. We're trying to figure that thing out. And I met mine on the dance floor, so.
But we're gonna dance together. So
yeah, we're gonna figure it out. Also to Esther Lurkies, it's been a pleasure meeting with you and your staff and your team, and thank you so much for having me and hosting me. So as I stated, this workshop will be interactive. I will share some of the information that I've learned in my journey, and also I will share some information that I've learned with a recent training with the National Institutes of Health. We were in Baltimore, Maryland for about 10 days doing a very intense 8 o'clock to 7 p.m. training. So I'm going to share some of that information with you today. Just as an FYI, it will be a primer because we had 10 intense days of training. I'm not going to do that to you all. So I'm going to briefly cover some concepts, give you some meat and some material to reflect on. And then, as I stated, it will be interactive. So I am not going to sit here and talk the whole time. My mom is with me today. I do want to acknowledge my mother. She is a retired educator. So I get my, yay. Thank you so much for joining me and being with me for today's session. We've had a ball the last couple of days, and she is an educator. I have learned everything about education from her. I don't know that I've taught a lot in front of her, so I'll be interested to hear her critiques because she'll give me the feedback. But I'm so glad to have her with me, and it just means a lot to have you here, Mom. And as we are giving out the boxes, I do want to talk a little bit about our learning objectives for today. So we have 3 learning objectives. We're going to talk about methodological approaches for intervention development. I will break these down for you so it makes simple sense. So we'll talk about stepwise intervention in the orbit model. We're going to learn techniques for successful, culturally inclusive, and community-engaged research with diverse populations. We'll talk about the EMIC approach and Picori's model for community-engaged work. And then lastly, increase awareness of funding mechanisms. So we all have these ideas. So oftentimes we have these ideas, we want to do these new programs and interventions, but we need money to do it. And so we're going to talk a little bit about how to locate and find that money. So that's where we're going today. Also, as an FYI, Becky, thank you so much, has added to your calendar link for today's workshop. If you go to the link for today on your calendar, there is a Google Drive link there. If you click on that Google Drive link, it has all of the slides for today, and it has some articles and resources that I'm going to reference throughout the training. Okay, so that is available for you. I'm a visual learner, so I like to pull up my slides while the slides are up, so I just wanted to make sure that you all had that available. All right, so the first couple of slides I'm going to cover, I think it's maybe two or three slides, are going to be somewhat of a repeat from yesterday, but I needed to center you all again today into this space. So if you are here again and you're hearing this again, just soak it in again and see what maybe you're hearing differently this time. So on this slide, there is a legal scholar named Patricia Williams who wrote a book called The Alchemy of Race and Rights. And she states in the gray material, I am interested in the way legal language flattens and confines and absolutes the complexity of meaning inherent in any given problem. So that's what she wrote. And then to the right, to your right, you'll see in blue, she says, since subject position is everything in my analysis of the law, you deserve to know that it's a bad morning, I am very depressed. It always takes a while to sort out what's wrong, but it usually starts with some kind of perfectly irrational thought, such as, I hate being a lawyer. Patricia in the blue keeps it real. The legal field and the profession in the gray is how she's trained to write and present. But we really get an idea and understanding of how Patricia really feels and her position on things when she keeps it real. When it comes to research, we are trained from a very objective lens. We are trained to sound alike, do the same thing, act alike, show up alike, write our articles, manuscripts alike. However, in that objectiveness and likeness, sometimes we lose the essence of who we are. When it comes to community engaged work, it is extremely important for us to be able to authentically show up exactly as who we are, because our community partners can see when we're being fake. They can see when we're showing up in the gray. Okay? So when we're going in with this objective language and speaking all these large research terms that they have no clue what we're talking about, and some of our colleagues don't even know what we're talking about, it's not helping us with the community. We have to be real, and we have to show up in the blue, and be willing to engage at a level where everybody is understanding. Okay? And so Patricia shows us that contrast in how she shows up in the profession and how she really wants to show up. And her argument is that it's important for us to be able to authentically show up in who we are, and that the solutions that we are seeking require us to be authentically ourselves. As long as we continue to walk around as robots sounding and looking alike, we're not going to solve the problems that need to be solved. We're going to keep running into the same issues and problems. So along that same lines, let's talk about breaking out of the box. So you have the box in your possession. If you can hold the box for me if you're able to. And as you look at this box, I want you to notice its weight, its size, its color, its shape. And you're going to notice that everyone in the room has the same color box, maybe a different bow, but you all have the same color box. And knowing my mom and how precise she is, you have one little small piece of tape, and it's not going to be probably two pieces. I get that from her. And so you have that box. And oftentimes we are trained and conditioned to show up looking very similar and looking very identical in our boxes. However, if we were to put your identity into that box would probably explode because of the richness of who you are, okay? And I want you to think about your lived identities. Who are you? What is your gender? What is your race? What is your background? Where are you from? Some of us are from different areas. What is your body size and body shape? We each have different body sizes and body shapes. What are your abilities? Those are all things that are inside of your box. Those are all things that make you unique. And then, the other thing I want you to consider, and something I've had a revelation with, because as you hear me talk, and people who have been with me the last day know, I talk a lot about being a black woman. Like, that's just my lived experience. My lived experience is primarily as a black woman, so I talk a lot from that lens because that's been my experience. But recently, I also realized that in addition to being a black woman, I also have all of these amazing traits and qualities that make me uniquely the way that I am. So yes, I am a black woman, and I'm many other things. So I know that I am confident at times, and at times I am nervous and afraid. I know that I'm competitive, so when we have family games, I try to win every game. So I'm competitive. I know I can be bossy. That's just kind of who I am. I get that from my mom. I get my organizational skills from my mom as well. I know I'm friendly. I know I'm kind. I know I'm compassionate. I know that I am a work in progress. I'm working on some racial healing, so I'm working through relationships with people and trying to work through some of those things. That is who I am, and that's what makes me uniquely the way I am. So yes, it's my lived identities, but it's also my traits and qualities. And guess what? When you wrap all of that up, and if you put that in one little box, there is no other box that has everything that I have in it. There is nobody else in this world that's just like me. Nobody in this world that's just like anybody in this room. You were uniquely created the way that you are. But we are trained and taught to stay in the box. And we teach our kids and our students, I'm not saying you all, but we teach our kids and our students to stay in those boxes. And we gotta break out of the box. So my challenge to you, and my challenge to myself a couple of years ago, I would say at the beginning of COVID, I finally realized I had put myself in a box. I had limited myself based on what people thought I was able to do and what systems taught me I could and couldn't do. So systems taught me that I couldn't study. So I was trained, and when I was in my PhD program, I was told I couldn't study the black community because if I just did black research, black focused research, I wouldn't get published, I wouldn't be successful, I wouldn't get into the top tier journals or high ranking journals. That's what I was told. And so I was cautious with how I approached that topic. So I was trying to be more inclusive and just say, okay, well, let me just focus on minoritized populations and let me not just focus on my community, what I was passionate about. And a couple of years ago, I finally got to the point where I had to say, no, Sonyia, you are passionate about the black community. You are passionate about black youth. It is okay for you to unapologetically show up in that space and to be a black focused researcher. And guess what? I broke out of the box. That's who I am. And that's when opportunities started to open up for me and doors started to open. When I unapologetically showed up in who I am. So my challenge to each one of you today is to ask yourself, have I broken out of my box? When I think about who I am on a daily basis, do people authentically get to interact with who I am? Or are they interacting with who I claim to be or who I want to be to make them feel okay? Like, who are people really getting to interact with? And the day and moment that you decide to unapologetically come out of your box and fully show up, I want you to open up your box. And as I stated yesterday, there will be something life-saving inside for you. Okay? Now, as I frame that, I also want to introduce this information. So we talked about this yesterday in some of our meetings, and I was like, you know what, let me put this into a slide just to make it real for people, because this is going to connect to what I just mentioned with the box. So in talks yesterday, I was talking about what I learned to do, what I did with a friend of mine. We found ourselves sometimes like being all over the place. So we were like, oh, I'm interested in this, and I'm interested in that, and I want to study this, and I want to do that. And we had to figure out, okay, we are all over the place, we're not focused. How do we focus ourselves? And so we came up with this little process that we have for ourselves now, where we identified 2 to 3 lanes. And these are topics or subject areas that you are extremely passionate about. And I also call it like your unique agitations. What are those things that just irritate you? What are those things that uniquely agitate you that might not agitate anybody else? What are those things that you're really passionate about? We each have about 2 to 3 things that would fit in that topic area. So in a second, we're going to do an activity on that. But I just want you to, as I go over this, I want you to think about that. What are your 2 to 3 lanes? Because as we think through those lanes, that's going to help us with our intervention development some. And then, so you have your 2 to 3 lanes, those things, topics, it could even be populations that you're really passionate about. And then what we also do is we call it our discernment checklist. I had to go back and look up the name of it. So we call it a discernment checklist, and I included 3 items for you. So when it comes to opportunities, invitations to do talks or to work with researchers or work with the community, you want to begin to ask yourself some questions. So one of the questions is this experience in one of my lanes? So am I staying in one of my lanes? Or is this outside of the lane? Okay? So focus your work on what your lanes are. You're also going to ask yourself, do I have the time to commit to this opportunity? Because everything that sounds good, you might not have the time to do. And you don't want to do something halfway. Like you want to really give everything your all. So do I have the time to commit to this opportunity? And lastly, am I dreading this opportunity or will it be enjoyable for me? We found that we needed to create this discernment checklist, particularly as women and Black women, because we were being asked to do so many service opportunities, so much stuff for free, and that became a burden. And so we had to start saying to ourselves, okay, is this even in my lane? If it's not in my lane, then this is probably a no. So my lanes are anything related to mental health, suicide, and particularly from both of those from a Black focused lens. And then my 3rd lane is education and educational systems, particularly for Black youth. So I'm looking at the interaction of educational systems and mental health outcomes for Black youth. Those are my 3 lanes. Those are the lanes I stay in. And those are the lanes where when people bring me in for opportunities, I'm trying to make sure, am I staying in one of those 3 lanes? Because those are the 3 things I'm passionate about. Those are the 3 things that when something happens and I hear statistics and data, I'm like, oh my God, this is doing something to me. It's just agitating me. I have to do something about it. Okay? So that is our discernment checklist. And so as you are moving forward with the work that you're doing, you're going to identify your lanes, and then you're going to identify, and then I want you to, in life as you move forward, to use some discernment to say, is this the opportunity for me? Or is this a distraction to keep me from the stuff that I'm supposed to be doing? Because a lot of times things are distractions. Okay? So we're going to start with our first activity. For this activity, I want you to first identify what are your intersecting identities. So who are you? You might talk about your genders, or you might talk about your race, or you might talk about sexual minority status, whatever you're comfortable with the partner introducing yourself as. What are your intersecting identities? What are your traits and qualities? So who are you? Like what are those, like how do you define yourself? So first you're going to reflect on what are your identities, traits, and qualities. And then I want you to identify what topics or subject areas are you passionate about? Okay? What are your 2 to 3 lanes? Okay, so I want you to identify those 2 to 3 lanes. And then collaborate is who in this space shares similar lanes or similar interests. Because that's where we can start to look at some overlap with collaborations. Okay? That 3rd one, we'll do that, I'll do a different activity for that. But if you can focus on 1 and 2, and just spend some time reflecting, and then share it with a peer or someone next to you, and then that collaborate, we're gonna I'm thinking I'm gonna have us just call out our lanes. And then as people are calling out their lanes, you can hear other people that are in your lane. And then you can jot down their names, and that might be somebody you connect with maybe later on or during lunch this afternoon. But I want us to start thinking those things through. Okay, so let's do 1 and 2. Are there any questions? All right, so let's take about 5 minutes for the first 2. And if you have questions, let me know. And so we've shared our lanes and our experiences. We're going to move into talking about developing research and interventions in my lane. So I was going to give a break. Do y'all want to take a break now, or you want me to keep going until about 11? And feel free if you need to get up and step out or whatever. Break or keep going? Keep going? Okay. All right. So we're going to talk a little bit about developing research and interventions. And one thing I want you to consider is that to develop an intervention, so you have your lanes, you have the things you're passionate about, and then there's the notion of there are some problems that need to be solved. And usually the solving of the problems is through some type of intervention. And, you know, we have evidence-based interventions these days. We have best practice-based interventions these days. And all of that starts from the concept of a thought or a problem that you want to solve. And usually I would advise you to align your intervention with the lanes that you're in. So whatever lanes you're in or lanes that you're focused on, think about what is a problem that needs to be solved within those lanes that I'm in. And that might be where you begin to think through some possible interventions that you can develop. The other thing, so for that, I want you to think about that. I also want you to remember you do not need to be a researcher to develop an intervention. Some of the best interventions are developed by people who are not necessarily researchers, but out in the community and knows what works. So a lot of times when you're out practicing in the field, you've been able to implement some things and you've seen some good success with those things. And so you don't have to be a researcher to develop and come up with an idea of an intervention. But I would say it is advisable to then team up with people to help with that intervention development. So when it comes to intervention development, what's recommended is a multidisciplinary team. So you need people who have various experiences and expertise. I would advise that you need the community and perhaps researchers to come together on that team to develop it, so you can bring the science with what we know works in the community and you can merge those two fields. But there needs to be a multidisciplinary approach. But I do want to stress that it doesn't have to start with a researcher coming up with an idea. It can be researcher or community. But it is advisable to not develop it alone. So if you have an idea or you're at the beginning stages of thinking of an idea or a program or something that you might want to implement at your school or in your lab or at the university or in the community, I want you to realize you can't do this work alone. Intervention development is very messy. And it can have a high failure rate, meaning you implement it and it doesn't work and then you try something else. And so it's just easier when you have a team to implement that. So for the rest of our session today, I'm going to go over different models for developing interventions. I'm going to give you some different things to consider and think about. Some of the models one of the models is a little bit more complex, so I'll break that down, and then there are some that are maybe just a little easier to understand and follow. But today is just a brief overview of those models. And so as I move into this content, I do want you to begin to think about, just in your mind, what is a problem that I want to solve? What is a problem that's in my lane that needs to be solved? So my lane, I told you, was Black youth suicide. A problem that needs to be solved is trying to prevent death by suicide among Black youth. So my problem I need to solve is to figure out how to keep Black youth from killing themselves, from dying from suicide. That's the problem I'm trying to solve. I'm trying to figure out how we do that. There are a lot of questions about what's happened. So if you don't have the context, there has been a crisis of, they're calling it a national crisis of Black youth who are dying by suicide. And the rates are right now highest among the babies ages 8 to 12. So Black, for the first time ever, in the Black population, we have higher rates of death by suicide for Black kids than ever has happened before. With suicide, it was always the white children, and this is, I'm speaking Black-white right now, but it's definitely other races to consider and ethnicities. But white children always have had higher rates of death by suicide. But over the last couple of years, there's been an emergent trend where the rates are increasing for Black youth. And right now, for the first time ever, like I said, Black babies 8 to 12 now have the highest rates of suicide, and they have outpaced white kids. So everybody's trying to figure out what's happening. My purpose is not to figure out what's happening. My purpose is to figure out how to stop it. Now, some might say, well, to stop it, you got to figure out what's happening. And yes, that is a pathway to figuring out what's happening. But my goal is to address and find those kids now that are thinking about it, or considering it, or planning it, and figure out how do I interrupt that and stop that, and how do I save those lives. And not I, I'm saying I, it's not an I thing, but that's my lane and that's my purpose, and I'm trying to figure out how do we do it, okay? So that's a problem that I want to solve. As I think about my mom talking about working with these kids, the problem she's trying to solve perhaps is how do we make sure the kids are taken care of when there's domestic violence and that they aren't forgotten and overlooked? How do we care for the kids? How do we restore these kids, restore hope and joy in them in these bleak, perhaps bleak circumstances and times? That's a problem she's trying to solve. So just kind of think as I go over these slides, what am I trying to solve? What problem am I trying to solve? And that is where you begin the beginning of your development of your intervention. That's ACL injuries, or I think we both had ACL injuries and tears. Okay, what is the intervention? What are you trying to solve? What are you trying to prevent? And you might just say to yourself, what is the research saying? Or what are people complaining about in the community? What are some of those common things that I'm hearing that need to be solved? And I'm going to frame this, the talk deals with minoritized populations. And we use the term, just to give context, we use the term minoritized to refer to groups that have been historically marginalized by society and institutions. And if you have noticed, they've replaced the term minority with minoritized because minority focuses on numbers. And it's not about numbers, it's about systemic biases, systemic racism, and things like that. So minoritized is more from the idea and notion that certain groups have been historically marginalized. I say historically, it's not just historic, but they have been historically marginalized and are currently marginalized. And those groups can include gender, so oppression of women, oppression of people who are trans, it could be oppression of racial groups. And the minoritized groups term allows for an intersectional perspective. So for me, I'm Black and I'm a woman. So minoritized, I'm in my own minoritized group as a Black woman. So that term minoritized encompasses intersecting identities. So it's a more proper term to use because it's not minorities, it's not a number, and that number actually isn't accurate anyway. So I'm speaking about intervention development from the viewpoint of minoritized populations. Along that same lines, I spoke about this briefly yesterday, there are two perspectives when it comes to approaching intervention development and research. You have the emic perspective, which is when we have an insider's view. So when you think about all of those lived identities that you have an insider's view. So myself being a sister, I understand what it's like to be a sister. People who don't have a sister don't have that experience. So I have an insider's viewpoint of being a sister. I know what that's like. And then you have an etic perspective. This is the individual who has an outsider's point of view. So if you don't have a sister, and I do, I have an emic and you have an etic perspective. When it comes to intervention development, particularly with minoritized populations, it's important to be able to merge those two groups together. Sometimes what you find is we do research, but we do research on people and on populations we don't know anything about. and we're not part necessarily of those lived identities. But when we can bring other people with those lived identities into those spaces, it creates a very nuanced understanding and perspective on how to really solve some of those issues. And people with those lived identities and experiences can help us, if we have an outsider's view, to interpret some of what we're seeing. Otherwise, we're interpreting data and interpreting findings with an ethic perspective, and we don't have that insider's point of view to really understand how to break that down and interpret it. And so, even, I think she left, but when she said, it was a professor, I think when she mentioned deep health, and someone said that's deep. Deep for me has different meanings as a Black woman. And I'm not sure of background or anything like that for the researcher, but I might give a different perspective to what that meant, because I haven't, and I don't know the research, I don't know the participant, but it's deep, conveys different meaning for me because of my background in language and knowledge. And so that's the importance of bringing together the emic and ethic, okay? So when we're working on our projects and developing interventions, we want to have people at the table who have those lived experiences, who understand. We're going to talk through some design elements and some different models that you can use for intervention development. But first I'm going to start with basic design elements. So on this slide you see basic research to the left, and then you have translational research to the right. Think of basic research as I'm doing research and I'm doing a single trial. And I'm going to explore this topic or this issue, and I'm doing exploratory study, I'm looking at effectiveness, focused on statistical significance, and because I'm doing this trial and it's a single trial, I have a fear of failure. So I want this study to really do well, because it's basic research and it's a single trial. So it has that fear of failure. You want it to work out. You also want there to be representative participants. So you're very focused on trying to make sure your sample and who you have involved in the study is very representative and diverse. Okay, so that's basic research again. Basic research is more focused on innovation, and it's designed to improve knowledge. So most of us have been trained, well, I'm making an assumption. I'm assuming that most of us have been trained from a basic research perspective. At least I can say I have been trained that way. And then when it comes to intervention development, though, when we're developing interventions to see if something is going to work for a population or for a larger group, we then need to move more and transition more into translational research. Translational research is when we have a progression of studies and trials. So I'm not now just doing one study. I'm doing this study, and then I'm going to move this study to the next level and add to the study, or I'm going to take out some mechanisms from that study because perhaps this didn't work. And when you are doing progressive research, it's a progressive process when you're trying to move it towards a larger endpoint, you expect failure. So I'm expecting the research to fail because the failure helps me to inform my future research. And it helps to inform my intervention. So when there are components of the intervention that aren't working, I then maybe consider removing those components from the intervention and then trying it again. And so you expect failure because failure is part of intervention development. And that's how you move something progressively along. Oftentimes what we do is we participate in a research study, and let's say the outcomes aren't what we expected, and then we leave it alone. And we put it on the back shelf. And then we say, okay, that didn't work. But translational research is we do a study, and if, let's say, it didn't have the outcomes, we say, okay, well, what about this didn't work? What could we add to this intervention? What additional components could we add? How can we change dosing or frequency of what we're doing, of what the program is? How can we change it and modify it, and then continue to test it and move it along this progressive model versus that basic single trial research where you do it one time and it fails. So the model I'm going to introduce to you today is the orbit model. And the orbit model is a translational research model where there's an expectation of failure because failure helps to inform the research. So for example, to break it down a little bit more, if you're doing, let's say you all are doing I'll just use the early middle school, for example. Let's say you're doing an intervention at the school with your kids and you want to test something out. Let's say you're collaborating, and you are, I think, collaborating with researchers here at UNCG, and then you all find out, okay, it didn't really have the outcomes we expected. You don't put that away. It doesn't go on the shelf. The researchers don't stop studying that issue. They then come back and say, okay, what did we learn? And then what can we do differently? And how can we test this differently? Maybe in the same setting and maybe with a different group of kids and see, okay, what components of this intervention are now maybe working better? Or what components do we definitely need to remove? So you continue to progress. When we think about community engaged research, the community has been frustrated because we've been doing basic research. We come in and do that one-time study and then sometimes researchers leave back out. But when it's progressive and we're trying to get to an endpoint, which is a successful intervention, then we continue to engage with the community and the community continues to depend on us to come in and provide needed services or interventions at their schools or in community organizations. So the goal is to transform us into translational research where the goal is to have long, sustaining relationships in the community. And we work in partnership with the community to not only perhaps test interventions, but to also continue to stay there to see them to success so that the populations that need the interventions get what they need. Let's see, also within the translational research model, we use a fail early, fail fast approach where we can identify what doesn't work early in the process. So it's fail early, fail fast. So the goal is to test, and if it fails, if it's not failing, to fail early and fail fast so we can make modifications before we take that study or that intervention to scale. All right, so I want to move everybody from this fear of failure to an acceptance that failure is necessary for the development of interventions. We have to be willing to implement knowing that it might not work so that we can learn what didn't work so we can modify the intervention and try again with something that might be more efficacious. So this is the orbit model, and I just have 2 slides on this, and I'm going to talk high level for this. I'm not going to break it down because we literally spent 10 days on this model, so I'm going to just kind of do a very brief overview of this model. So the orbit model was developed by Shazowski and Powell and colleagues in 2015, and this is a progressive translational model. And what you'll notice from this model is that it moves interventions from the significant clinical questions, so discovery phase. It moves them all the way to phase 4 effectiveness phase. So in behavioral research, most research is phase 2, which means we engage in preliminary testing, feasibility pilots, and efficacy trials. But in medicine, when we think about like drug development, the reason why drugs go to market is because they reach all the way to phase 4. But oftentimes with the research that we're doing, we don't get to phase 4, which is why there aren't as many interventions and evidence-based practices that we're able to actually implement or that are available because they get stuck in the process of intervention development and we don't progress it along. So in this model you can see here, it starts with a significant clinical question. So where I ask you all, what problem are you trying to solve? That's where you're developing your significant clinical question. So what is it that I want to solve? And you got to discover that. And you can discover that through research, through interactions with the community, finding what works and doesn't work. And then you'll see phase 1 moves to the define stage, where we define the scientific foundation and basic treatment elements. Now to define what's going to be part of your intervention, so if I'm doing a Black youth suicide intervention, I need to figure out, okay, what exactly do Black youth need as it relates to preventing suicide? I'm going to have to go to the research for that. So that's going to be examining some systematic reviews or some meta-analyses to dig deep to find out what's happening there and how do I need to develop this intervention and what are their components for it. In phase 1, it also includes the refine stage, where you refine the intervention for strength and efficiency. And then it goes to the preliminary testing. All right, so you have your discovery, your design, and then the preliminary testing includes the proof of concept model. It also includes feasibility pilots. And then, y'all, I'm at the age where I can't hardly see. I mean, I've laughed at my husband the whole time, but I think I'm almost there. And then it has efficacy trials are included in phase 2 as well. So in that phase, you're looking at really trying to optimize it. And the question is it plausible that the intervention can achieve a clinically significant benefit? When it comes to intervention development, we are focused on clinical significance and not statistical significance. So you're seeking clinically significant different outcomes. So is there some clinical significance and difference? And you're using that clinical significance based on what the research already postulates for what includes statistical significance. As we move along here, it defines and breaks down each of those trials. And then the ultimate goal, as I stated, is phase 3 and phase 4 progression. So that's what we're seeking to move towards. Long story short, for this model, the key features is that you're beginning with the end in mind. When you move towards the phase 3 or phase 4 process or step of your intervention development, when you move towards that phase of the intervention development, that's when you've developed an intervention that can possibly go to scale. So the goal is, think of it this way, the goal is when we're developing an intervention, it's not for me just to be able to implement the intervention in a local community and the local community benefits. When we develop an intervention and we take it through these scientific phases, the goal is to develop a model that can then perhaps be accepted as a proven treatment modality or something that's going to be effectively used to treat some particular health issue, mental health issue, etc., and potentially for insurance companies to be willing to reimburse for it. So the only way it's actually going to get out to the community and have the national impact that we needed is if we take it along these steps and attempt to get it to phase 3 and phase 4. But just notice, you can't get to phase 3 or phase 4 until you've gone through the other stages. And the other stages require you to be willing to fail to be able to progress into the next stage.
So, can I ask you a question?
Yes.
Can you also think about phase 3 and 4 as maybe withdraw the researchers where it's sustainable within the community? You know what I'm saying? Where it can continue.
Yes, yes. That it can continue, that it can survive, or can actually be wide scale, like have wide scale implementation.
Yeah, when you think about scale up, is that also scaling it where the community itself can sustain it?
Absolutely, yes. It's to get it. The idea is to get it out of our labs, to get it beyond local context or wherever we're implementing it, and really to get it towards more widespread use.
Because that's one of the problems with, there's a lot of studies of ACL injury prevention, for example, but as soon as you take the researchers out, then it's not continued, and it never makes it to a national implementation, so other than the local.
And the argument of these researchers is because it hasn't gone through full scale, it hasn't gone all the way to the phase 4 effectiveness, which I think I spoke about yesterday, the costing of interventions. So like when you're developing an intervention or you're doing an intervention program, if I'm doing a Black youth suicide intervention, I need to be able to begin thinking about costing at the very beginning of that intervention. So how much is it going to cost to implement? How much, like who's going to be involved? If it's going to be a social worker at the school, what is the cost of their time? What is the cost of the time of the participants? What is the cost of the intervention, the training components? You're thinking through those things. Because if you get it all the way to the end and it's such a huge cost, that insurance companies and families aren't going to be willing to pay for it, then it's not, you haven't really prepared that model to really have wide-scale implementation. So you're thinking about cost at the very beginning. So as you're developing interventions and thinking about how am I going to solve these problems, you're also thinking about what are the costs related to this, and how can I minimize or reduce costs so that it can have more wide-scale implementation. I didn't tell you the ORBIT model stands for, let me get it right, it's, I don't see it on the slide, but it's, it was an obesity study. And I think you studies obesity, Sandy? Or somebody does,
It's kind
yeah.
of secondary to, yeah.
Okay, that's what somebody. Yeah, so this was based on an obesity study, and if you look in your drive folder, there are a couple of articles. I think I have 2 articles in there about ORBIT, so you can read more about the entire model and the phases and how they break it down. But I did want to give you some of those key features. So the idea is progression. So when we think intervention development, I want you to think, how do I progress it? And how do I accept and get past that fear of failure and accept failure as a normal part to intervention development? Now the thing with the ORBIT model is it is flexible in terms of oftentimes we start and we go back. We start and we go back. So you're going to find yourself, you might develop the intervention or come up with an idea. You develop it, you define it, refine it, and then maybe you do a proof of concept, which is a very small scale study. And then you say, okay, that didn't work. And then you go back and you define it and refine it, and you're allowing yourself to go back to those phases. So optimization is on a continuum because you're constantly having to go back to beginning stages to optimize that intervention. And with this model, as I stated earlier, it requires a multidisciplinary approach. So you have to have, it's necessary and vital to have different perspectives at the table and interdisciplinary perspectives at that table to be able to give insight. So for our National Institutes of Mental Health, initially we did not include costing in our intervention, and part of their recommendation to us was to include costing. So we now have an economist who's helping us with figuring out a costing model for our intervention in these early stages of development, because we didn't think about that at the very beginning. Okay, so that's the costing factor, and those are some things that you're beginning to think about. So that person brings an interdisciplinary perspective because that's their area of research, and that's where they can help us to think those things through. Okay. Also, in our intervention development, we have we are engaged in community engaged research, and so we have a community collaborative board. So a community collaborative board is a group of stakeholders and people from the community, leaders from the community, who are helping us in implementing, designing and implementing our research study. We have for our community collaborative board, we have about 15 people involved with that board. We have the major hospitals, local school systems. We have nonprofit organizations, faith organizations at the table. And we have 2 co-chairs of our community collaborative board. So just kind of imagine when you're engaged in community engaged research, a high recommendation is to have that community collaborative board so you can have the voices at the table to help with implementation. With that community collaborative board, as I said, we have 2 co-chairs. We have an academic co-chair. So we have someone from the university who's an academic co-chair, and we have a community co-chair. The reason for the 2 co-chairs is sometimes the academic co-chair is having to break down and explain the scientific elements to the community co-chair. The community co-chair, though, is leading the community collaborative board meetings. So they're in charge of those meetings, and the academic co-chair is coming back to the committee and giving us updates on what we need to know about recommendations from the community collaborative board. So we have both people as co-chairs and co-leaders of that community collaborative board. Okay. And the community collaborative board is giving us feedback and input on most, if not all, aspects of our study. So they're looking at our recruitment flyers, our enrollment processes, who we're reaching out to for enrollment, how they've looked at our enrollment procedures. So when we enroll people in our studies, they're giving us recommendations, okay, maybe don't say that and say this. So they're helping us to refine all of those elements. And so it's a very community engaged process, and the community is in partnership with us implementing the study, and they are learning about research while we're learning more about the needs of the community. So we're both learning. They're teaching us and we're teaching them at the same time. Any questions so far? All right, so this slide, I was just going to break down this first. I think I just have this last slide for this model, and we'll walk through this just a little bit. But when we think about that significant clinical question, that is the question that you're seeking to solve, the problem that you want to tackle. And the slide says, what is a significant clinical question? So it could be a disease that is increasing in numbers, severity. It could be something that exclusively affects or is increasing in a subgroup. A health problem for which no treatment exists, or the current treatment is not very effective. Something that requires a new approach, or it involves a novel risk factor. So you're trying to think through, what is my significant clinical question? What do I want to solve? And what is it that I'm seeking to either interrupt or eliminate, etc. And then on the right, it has, how do we identify what is significant? This is from providers, healthcare systems, payers, the public health officials, community leaders, community members, evidence reviews, individuals, patients, and their families. So it's what we're hearing from the community, what we're reading in research articles, what we're noticing in our organizations. That's how we're identifying what is a clinical significant issue for us to solve. When the Congressional Black Caucus in 2019 said that there was a crisis of Black youth suicide, then that became the significant clinical question. How do we eliminate and end or reduce Black youth suicide? That became the significant clinical question based on policy, based on public health officials and what people were saying was a problem, okay? So as you're thinking through a clinical significant question, you're thinking through what matters and what are we currently hearing are some of the issues that need to be addressed. So one model that you all have may have seen before is PCODE for defining and designing the study. So my goal was just to have you to just begin to think about an intervention. We definitely wouldn't have time to develop anything today in our time together. But I want you to begin to think about define and design an intervention. And so this is a brief model, simple model for how you can begin to think about that. So I want you to ask yourself, who or what is the patient population or problem in question? Who is it that I really want to focus on? Who do I want to, who do I really care about? Where is my lane? What is that population? And you want to be able to define or identify that population. So for me, my population of interest is Black youth, and more specifically, I'm really interested in Black girls. So that would be my patient population or problem. And I would say Black girls who have high rates of suicidal ideation and behaviors. So what is the intervention or treatment being considered? What is the intervention that I'm wanting to develop or I have developed specifically to deal with that problem that that population is facing? So let's just say if I was interested in, so I'm an educator, but let's just say I'm interested in school disciplinary rates, right? And I'm interested in disproportionate school disciplinary rates. Okay, so I'm interested in that. That's the problem. What's the intervention? What do I want to try? How do I want to try to intervene with that? Is it a new classroom management technique or intervention that I want to develop to assist with that? So that becomes my intervention. The comparison or control is what other interventions should be considered. So I might consider another intervention, or I might consider what is currently happening in the classroom. which would be treatment as usual. That would be our control, perhaps. And so if there isn't an intervention being offered. So you're comparing it to what may exist, or another intervention that's being included or implemented. And then outcome. So what is the desired or expected outcome? What am I hoping to achieve? So perhaps if I think about school disciplinary rates, maybe the outcome I'm hoping to achieve is to decrease disparities, and maybe even just to decrease rates of suspensions and expulsions. That might be my desired outcome. And then time frame is how long will it take to reach the desired outcome? So when you're thinking about your intervention, how long is that intervention going to take? So this model, the P-code model, was introduced in 1995 by Richardson et al. And it just helps you to kind of bring your intervention or the area you're studying. It really just helps to refine it just a little bit more. So this is an example of a research question that uses P-code. This is more healthcare based. But a question is, do diabetes prevention program translational interventions work in primary care? So you have your populations, adults with high BMI and cardiometabolic risk factors. You have your setting. That one's going to be in primary care clinics and a large ambulatory care system. What is the intervention? Coach-led in-person groups and self-directed videos. The comparator here is usual care. What is the outcome? So what is the overall outcome you're expecting from the study? Is weight loss is primary. That's our primary outcome. And then we have other outcomes listed as well. And then the time, primary time length looks like it's 15 months, but there are other time points along the way. Now this is a study that our intervention that has already fully been developed, and they've been able to kind of think through all of these time points and outcomes. We're at the very beginning, well, for this workshop, I'm at the very beginning stages with you all, with thinking through that intervention development. But what I want you to think about, and you could be further along, and that's totally fine, but what I want you to consider is, for the problem that I want to solve, or that I'm seeking to solve, how does P-code apply to that? What population am I focused on? What population am I most concerned with a particular issue, or what problem do I want to solve? What setting am I going to focus on for this intervention, or for this program or intervention I'm going to try? Comparator, if you know what currently exists, or if you want to test it against a different intervention, what is that comparator? What are some initial, I'm just brainstorming outcomes, what are some of those outcomes I want to consider? And how much time is it going to take, am I estimating it's going to take to implement this intervention? Okay, I'm going to keep it moving, but you can continue to think and reflect. And again, this doesn't take like 2 minutes to think through. It takes a lot more steps and processes, but I just want you to start thinking through some of these ideas, or trying to structure some of your thoughts a little bit more. Also know that intervention development is messy. It's a very messy process. And so it's going to take practice and application, etc. All right, so that is P-code. And then just very briefly, you have these slides, so I'm not going to go over these in detail, but that phase 1 design, when you define your study, you're defining the foundation and basic treatment elements. And these are some of the things that it suggests you should consider for the design of your study. And when you think of design, the study designs and methods, this is going to be systematic reviews, observational studies, qualitative and mixed methods research. These are different parts of the define phase where you're defining your intervention. So you develop your significant clinical question, and then you begin to think through defining the elements of the intervention. So what are the components? What are the elements exactly of this intervention? And then in this first phase 1 design, the last one I'm going to cover for you is just refine. With this one, you're refining the intervention for strength and efficiency. So now I've identified the preliminary components of the intervention, So if I'm doing a Black youth suicide intervention and I'm doing care coordination for Black youth, I've identified the essential components for the intervention that we're going to implement. I've also determined how it's going to be delivered, how it's going to be dosed, how frequently they're going to have services, the duration and intensity, and I'm going to determine if I need to tailor that intervention for certain subgroups. These are all parts of the refining process. So again, you're going from the significant clinical question to defining and to refining. So considerations. What we know is that after decades of research on psychological disorders and treatment, approximately 65% of patients still do not benefit from treatments provided in clinical settings. So despite all the research that we've done, 65% of people still don't benefit from any of the treatments that are in place. 65%. And Friedland tried to understand, okay, why are we not making progress with outcomes? Why are not more people not being impacted? And there's an article in your Google Drive for this as well that goes through this a little bit more. But two areas he talked about is lack of commitment. And he talks about how we have not established better outcomes for people who need interventions because we're not going all the way to phase 5. So we're testing an intervention, doing basic research, it doesn't work, and that's it. And so we're not there's a lack of commitment to really progress interventions to the final phase 3, phase 4 research, or phase 4 statuses for that model. And then also a lack of incentives. Research funding does not incentivize our outcomes necessarily. So it's seeking for us to have these outcomes, but we're not incentivized necessarily for these outcomes. So as you progress along that model, it becomes more expensive to implement the research and more difficult to find the funding. And then there's less incentives for moving it along the research continuum. And so there's also some lack of incentives in the field. And that article talks a little bit more about that as well. The challenge again is to move it towards that. So this is a very simple model called stepwise interventions. And all of us are engaged in stepwise interventions whether we know it or not. Stepwise interventions, so when you're thinking about interventions to develop or interventions that you're currently a part of, there is this model, stepwise, where you have step 0, which is a readily available self-help resource that doesn't require intervention staff and that incurs little or no expense. So step 0 are those natural supports and resources that are available. So someone is presenting with some type of issue or behavioral concern or healthcare concern. Step 0 are those interventions that don't really require staff and have very little expense, but things that we can implement that don't have much cost. So we usually start with step 0. And then people may progress to step 1, which is a lightweight, cost-effective intervention. This would be more of like having community health workers in the community work on issues or peer support specialists. So this is something that's a little bit more cost-effective, but it's also scalable. And then we move to step 2, which are more intensive interventions, which usually have more costs. That might require more of a master's or doctoral level staff member to intervene. If you're thinking about a health-related issue or a behavioral health issue. And then you move to step 3, which is very intensive. And then lastly, step 4 is the last resort interventions. And so you see this oftentimes, like let's say if we're dealing with depression, we might go through these different steps where we're trying different strategies. So step 0 might be mindfulness activities. So we're doing mindfulness activities on our app. It might be a free app. That's available, it's something that we can implement, something we can use. And let's say that the mindfulness app is not really helping us to really deal with depression because it's not really treating depression. And it doesn't really give us that relief. We might then move to step 1. So maybe I'm gonna go to a local support group on depression, or a meeting of people in the community who are all dealing with depression, and we meet up and talk about our experiences. That would be a step 1. Step 2 might be, I'm going to see a therapist. I need a little bit more intervention because that's not working. I go to the therapist, that doesn't help, I might go to step 3, which is seeing a psychiatrist, now I'm prescribed medications. And then let's say that doesn't really help me relieve my depressive symptoms. Step 4 is me going up to an even higher level of care, which might be some partial hospitalization or another level of service, more intense services. What happens is with these steps, when we start with step 0 and step 1, a larger percentage of the population are able to be treated with step 0 and step 1. As you move along that continuum, there's less effective treatment options available for people. And there are still people, when they get to step 4, that still doesn't work. There's still people for whom though all those options have been exhausted and it's still not working. And so when you're thinking about your intervention development, the goal is to really think through what are some of these earlier steps that don't require a lot of funding, don't require a lot of staff and resources that we can implement that can still be scalable and cost effective at the same time. And so just the last couple of slides, in developing, so you could consider developing a new intervention or developing an existing intervention. So when developing a new intervention, you want to consider starting with scalable, implementable, cost-effective step 0 or 1 interventions, or you can consider starting with a more robust, intensive intervention to maximize efficacy, even if it's not cost-effective. And if it proves to be efficacious, then start working on a lighter weight, more cost-effective first-line intervention. So what you could do is develop the heavier weight intervention. So go robust in the beginning, and then scale that back some, based on which parts you think, if you were able to do any piloting, I don't know if you would, but if you were able to do piloting, which parts of it would be more feasible to actually implement at the same time while reducing costs. So I would say dream big and then scale back a little bit for cost. Okay, and then you could also develop an existing intervention where you have an existing intervention that has been well designed, is maybe already cost effective, empirically supported, and you're asking yourself, is it already there? If it's not, then you do something to move it into that direction. If yes, then you find ways to improve outcomes for patients who don't respond. So perhaps the intervention works, but not for every subgroup, and so I'm going to tailor that intervention a little bit more for other groups of people. So you can either develop a new intervention or you can develop an existing intervention. And these are some points for you to consider for that. So I'm not going to stop us here for this, but I do want you to just think about intervention development. What are next steps? What might you consider? If you're really interested in developing interventions, thinking through those design, refine stages, your clinically significant question, all those things that we discussed. And then I just have a couple of slides on the research that I'm doing, and just very briefly. One is a culturally adapted care coordination suicide detection and intervention model for Black youth. It's called the CA-LINK study. This is funded by the National Institutes of Mental Health. It's a 3-year study, mixed methods, where our goal is to test a novel care coordination intervention. So it was an intervention that was developed, tested in Florida, and we are taking that intervention and culturally adapting it for Black youth. With the mixed method study, phase 1 is qualitative research, where the Black community is helping us to develop and tailor the intervention to a model that they believe works for them and meets their specific needs. And then phase 2, we're actually implementing that model with a clinical trial and testing some outcomes and with that actual clinical trial. This is for Black youth ages 14 to 17, and we are using community engaged participatory research here. And then just a little bit about our outcomes for this study. We have some feasibility outcomes that we're measuring that you'll see listed. Our primary outcomes, what we're most concerned about, is reducing suicide ideation and suicide behaviors. And we're going to hope to get to those outcomes through some potential change mechanisms. And these are change mechanisms that have been specific for Black youth in addressing suicide and mental health challenges. So our model and our intervention is focused on these areas of consideration. slide for you. I'm not going to spend time on this, but it's just considerations for evaluating and selecting outcomes. So when you're thinking about outcomes and how to select outcomes for your interventions, these are some of the items you want to consider. I have these listed for you, and you can reference this at a later point. This is also some resources. This has some really good resources for outcomes and measures. So if you're seeking outcomes and measures for a study, these are just 3 resources listed. You can go there, and they have banks of outcomes and measures that you can actually access that have been tested. And so these are kind of my go-to when I'm identifying outcomes. If I want to measure this, I'll go to some of these sources first and see what they have available to see if these are some outcomes or measures that I want to actually include into my study. So there are banks of measures available that have already been tested that are free and accessible through these sites. And then funding mechanisms. I have a couple of websites listed here. I don't think I'll be able to, I don't have my internet hooked up, so I can't click on them. But there are some funding opportunities listed for potential research. I have those listed here for you as you're considering opportunities. PCORI does provide funding for some of the work that I talked about today with intervention development, and they're very community engaged. So if you're doing community engaged work, they love to fund that. Of course, you know about NIH, the National Cancer Institute, DHHS, as you heard Dr. Morrison mentioned earlier with DHHS, you can approach them about proposals. So one of the funded projects I have with a community organization, it's a $5 million grant where we are implementing mental health hubs in churches. So Black churches in Charlotte, it'll be 10 churches total in Charlotte that will be centers of we're calling them mental health hubs, where individuals in the community, congregants, can get connected with a community health worker who will then be a bridge to connecting them to necessary mental health services or substance use services in the community. So we've already created a directory of Black physicians, social workers, counselors, et cetera, in the Charlotte region. So if people have preferences for providers that look like them, they can get access to that. And the community health worker is helping to link them and educate them about mental health prior to them getting to a provider and helping to facilitate that process. So that was something that was recommended to the state to address the needs of the Black community as it relates to mental health. Submitted a proposal, the proposal was funded, and now this community organization is able to implement this project. Okay, so as stated, you have North Carolina, DHHS, and you also have national. And then there are also SAMHSA grants available. And lastly, this is the last resources I have for you, and then I'll answer Sandy's question that she had. If you are considering evidence review, so let's say you have a research area that you're interested in, this is a link that will guide you to evidence-based reviews where you can see what's already out there in the literature for certain research. Sample grant applications are available. This is a link available for how to develop effective multi-stakeholder teams. So when you're developing teams, this gives you ideas and strategies for how to do that. For community members, this is a link that teaches you some basic research fundamentals. So as you're working with the community, if you want the community to be a little bit more understanding of the research process, that is it has free available modules for community members. You can use it even for students, where it takes them through some of the basics of research, and that's available as well. And I have that link listed for you. Lastly, when it comes to community engaged research, Sandy had asked me top 3 steps for engaging the community. So as you noticed by this talk today, the first part, I tried to keep it more, I was trying to balance. So I wanted to engage the community a little bit more and engage individuals who may or may not be heavily involved in research. And then I wanted to engage the scientific community as well with some information that they could use. One of the top 3 takeaways I would say for community engaged research is always be attentive to your audience. Always make sure when you're working with the academy or the community that you're speaking the language of both entities and that each entity is able to take something away. Okay? So you can't, like, sometimes it's hard to break everything down to a level where everyone in the community might understand. But try to as much as possible and just make sure each person has something that they can take away. But know that you have these competing demands. Okay, I need to be scientific, I need to cover this, but I also need to make sure people are able to understand and it's not too scientific. It's that wrestle. So accepting the wrestle. I would say secondly for community-based organizations, understanding their power and understanding and accepting that they often bring more wisdom to the table than we do. So the wisdom to the solutions that are needing to be solved is often going to come from the community and not necessarily from the academy. And so being in a place of humility where you can accept that you need the community to help in solving the problem because they probably have the better answers. Then what we have would be my second tip. And then tip number 3, I would say to be authentic and be real. Community can tell when you're not authentic and real. And be yourself and stay in your lanes would probably be my top 3 tips for that. All right, so you guys have pushed through 2 hours of training on a Friday morning. I really thank you and appreciate you for your time and your attention. It's been a pleasure. And I will hand it over to Cindy.